So the sepsis 3 definition is really good because it captures the group of patients that clinicians actually want to capture, and that is patients with life-threatening infection, so that we can give them escalated care and give them the best opportunity to survive. The complexity, though, with operationalising the sepsis 3 definition is we've moved away from bedside diagnostic criteria using the presence of a systemic inflammatory response to diagnose sepsis to organ dysfunction criteria, which may embed a delay in our diagnosis because we may have to wait for the results of blood tests before we can diagnose the organ dysfunction. Yet, we know that the only way of reducing mortality for patients with sepsis is early recognition and early treatment. So what is the approach we need to take? Well, it's really very simple. We need to treat the patient in front of us on the basis of how unwell they are when they present. So how do we identify these patients? Well, we've used our national database to identify 3 groups of patients who have a mortality risk of over 20% if they have sepsis. So if patients within one of these 3 groups present with an infection or symptoms and signs suggestive of infection, they need to be designated Category 2 and escalated to early medical review, and if indeed infection is identified on history and examination as the cause of their being unwell, they should get the Sepsis 6 1-hour bundle up front. And part of that bundle is, of course, sending the blood tests that look for organ dysfunction. So when those blood tests are then available, the results are available, we can then make the diagnosis of sepsis or indeed septic shock if the patient fulfills that criteria. So who are these 3 groups of patients? Well, the first group is patients who are on immunosuppressant therapy who present with infection. And the classic person in this group would be the patient coming in febrile who's at risk of neutropenia because they're on radiotherapy or chemotherapy for cancer treatment. These patients need to be designated Category 2 and escalated appropriately. The second group of patients is also pretty obvious, and that's the patients who actually have clinically apparent acute organ dysfunction on presentation. And in our sepsis algorithm for triage, the so-called Think Sepsis algorithm, we list out the criteria, the clinical criteria for acute organ dysfunction on presentation. And these are different for from the criteria for the systemic inflammatory response. And so you need to check them out on your Think Sepsis posters. And the third group of patients are patients who present with a systemic inflammatory response and who have a comorbidity, because we know that patients with comorbidities, when they present with an infection, have a very high risk of mortality if indeed they have sepsis. So who are we not escalating that we previously escalated on our old algorithm? Well, it's the patient who presents with infection, who may have a systemic inflammatory response, but they have no comorbidities and they have no clinical signs of acute organ dysfunction. These patients still need to be seen by a doctor, they still need to have their infection assessed and treated appropriately, but they don't need to be escalated to immediate medical review, so they can be designated as Category 3. However, should their symptoms and signs progress and they become more unwell, they should be re-triaged and escalated to medical review.